I would like, first of all, to thank all the organizers for inviting me to give this talk. And the topic of my talk will be about new and old strategy to improve adherence to antiretroviral therapy, what works. So this is the roadmap. I will try to define first the UNAIDS 90-90-90 targets, adherence requirement for virological suppression, patient regimen-specific barrier, evidence-based intervention. I will start with the old and finish with the new on horizon. So the first picture just show you how far we came as far as antiretroviral treatment is concerned. People are brought from death to life with life-saving antiretroviral, and this is only possible if people are patient adhere to their treatment. The 90-90-90 UNAIDS target, which basically is defined that 90% should know their status. Of those 90%, 80% on treatment, and of those know the treatment, at least 73% are virologically suppressed. And based on the recent data just before the COVID pandemic, you can see where we stand globally, from the Africa, from the Americas, from the Asia, but globally, things are not too bad in terms of people knowing their HIV status, being on treatment and being virologically suppressed. You can see that it's fairly quite well. And again, this was before the COVID lockdown. But the success story, just give an example, this is Botswana. Botswana, they've been able to have almost, so basically about the 70% of virologically suppressed, which is really great. A small country in Africa, which has been at the forefront of antiretroviral treatment from the beginning of the pandemic. So adherence to treatment, as I used to say, it's a multifactorial equation. You have to be accepting the treatment. At the same time, you have to have a very potent treatment, be willing to adhere to treatment, and hopefully have a treatment that is less side effects. And based on that, you have to have also not have any issue about pharmacokinetics, absorption, metabolism, drug interaction. And if you meet all those requirements, then either you virologically suppress because you take your treatment correctly, or you're not virologically suppressed, then you reach virological rebound, drug resistance, and transmission to the community. So adherence, as I say, it's really a multifactorial equation which going to depend on several factors. And this is I just went back historically to our study to understand adherence to HIV treatment. And as you can see, this is the old data from Patterson in Annal of Internal Medicine. And unfortunately, this slide, you cannot see very well the number on x-axis. So basically, the higher the adherence, the higher the virologically suppression. But this was with the old PI protease inhibitor based regimen. My group at Hopkins, and my colleague at Hopkins, we replicated the data using not the PI-based regimen, but the non-nucleoside reverse transcriptase-based regimen. And this is what we found, again, replicating basically Patterson relationship, but this time with non-nucleoside reverse NNRTI. The higher the adherence, the higher the virologically suppression. And this is a really nice dose-response relationship. But as you increase adherence, you're gonna also, we show with my group at Hopkins that you decrease also the costs, healthcare costs associated with treatment. As we show here, the fourth quartile are the quartile of excellent adherence, and the cost of hospitalization is very lower due to improved adherence and less likely to be admitted for costly opportunistic infection. So this relationship has been confirmed also by other colleagues. This is data from Martin, published in AIDS Research Retrovirus in 2008. But the advantage of this slide, it shows you basically head by head a comparison between the unboosted protease, the boosted protease, and the NNRTI, really showing that as you get to boosted PI are the most robust on drug resistance. And this is defined by this relationship that we use to compare. You cannot get drug resistance if you don't have drug pressure. It's only when you have drug pressure that resistance emerges if you're not fully adherent. But people who are not adherent, are not taking any treatment at all, the mutant virus which dominate. On the other spectrum, if you are fully adherent, you fully suppress, there is no emergence of drug resistance. Drug resistance emerges at the no man's land of drug pressure. And this now putting the different type of drug, and it's shown nicely that NNRTI, the green, are very vulnerable. It just depends on single-step mutation to emerge, the drug resistance to emerge. It's only the boosted PI who are most robust on forgiving of non-adherence. And that forgiveness, it also nowadays with the new regimen we're using, which is the integrase inhibitor like dolutegravir. Dolutegravir also behave like the boosted PI in terms of their forgiveness for small, non-adherence episode. And the way we used to measure adherence, we all self-report, pill count, pharmacy refill, and even more in research setting, electronic monitor. You are familiar with all those measures, but in clinical practice, self-report, pill count, and pharmacy refill are the most used. So this is just a picture just to remind you the MEMS caps we used to use in the time for research, which are more reliable and more objective. So going to barrier to adherence, again, let me just say the barrier to adherence, the most common one that we're facing even now in the COVID era is mental health, depression, and substance abuse. A lot of our patients face issue about not only depression, but also substance abuse. Those two barriers goes hand by hand, as you can understand. And if you treat mental health, you treat drug abuse, you improve also adherence. Other issue, barrier to report, which can be just operational or social issue like housing. All those are also familiar, sometimes also goes with mental health, substance abuse. The most other type of barrier that has been shown, this is data actually from Rio de Janeiro, Brazil, showing that key population, this may be drug user, but this is in men who have sex with men. So this is also, it's been shown that they perform poor in terms of antiretroviral treatment adherence. So there is some specific demographics which are at high risk of non-adherence. And want to be sensitive and trying to engage in some intervention to improve adherence. Adolescents also are at high risk. Also, virological suppression has been shown to be very challenging in this population. So whether we talk about old intervention or new intervention, so those are the key population that we need to tackle. Another population, special population, vulnerable population, are pregnant women. Our data show that pregnant women during pregnancy and postpartum, the adherence is very low, and this is at risk of transmitting the virus to the baby. So this is also important to engage in intervention to maintain adherence during pregnancy and during breastfeeding period. So now we are in an era of COVID. After 3 years of COVID, the question you will have is how COVID did impact HIV treatment 90-90-90 target, UNAIDS target. So the most comprehensive paper published in the Lancet look at impact of COVID lockdown on HIV care in 65 South African primary care clinics. This was an interrupted time series analysis, and the conclusion they came up with that antiretroviral treatment program was generally maintained in terms of people collecting their medicine every 6 months. They try to distance the time of collection. They show also that somewhat virological suppression was not mightily impacted. What was impacted was the proportion of patients initiating treatment was somewhat decreased. So the bottom line, WHO has been recommending during the COVID era strategy to try really to maintain highly functioning antiretroviral program is to embrace community-based model of care, less frequent visit at health facility by distancing medication pickup to 3 to 6 months, every 3 to 6 months, expanding mental health strategy program, and also improving people center of care at the community level. So let me go back to some of our old intervention that has been evidence-based and that were published in the Annal of Internal Medicine some time ago in 2012. They're still valid, most of them. And I will just say counseling is still relevant, evidence-based. It makes a difference. And nowadays, you can do telemedicine, counseling, remote counseling, so that works in the COVID era. Two-way patient support through SMS has been also shown to improve adherence and virological suppression. So those are interventions that still make sense, especially in the COVID era because it's remote. And this was, we updated those recommendations some time ago in terms of the mHealth weekly SMS support. Try to decrease, simplify treatment simplification. Obviously, before the COVID, we had once daily treatment. At the end of this talk, I will just end up with the future treatment, which is the long-acting antiretroviral. So we, in the process of hopefully in the next few years, we may maybe just rely on once a month or once every 2 months long-acting antiretroviral. So treatment simplification toward once daily treatment is still valid. Our meta-analysis some time ago confirmed the impact on virological suppression. Directly observed therapy is not recommended. Actually, it's not practical, especially in the COVID era. But a community-based, family-based observation for some specific population may be of use. but in general, DOT for HIV treatment is not recommended as compared to DOT for tuberculosis. How about financial incentive? Financial incentive has been shown in HPTN in the US to somewhat improve a little bit adherence, and it's been shown also in mother-to-child program to PMTCT services in the Congo, in Africa, to make a difference on adherence. So those are also evidence-based intervention that can be used when available and affordable. But the one that I wanted to highlight mostly, especially in the COVID era, is the effort to decentralize, to have a differentiated mode of care for HIV, which WHO call DSD model. So those are to get treatment delivery at close to the door of the patient, and to have those community care by the community, so that they don't have to walk many long distance to come to pick up their medicine. And during those pickup of medicine at their community, they can have counseling in group. This has been shown effective in South Africa. This is in South Africa. This is in Mozambique. And it's been shown to improve treatment outcome. The last intervention, all the intervention I will say, is to try to initiate treatment rapidly, not to wait 2 or 3 months. But again, this seems to be the only aspect of HIV care that has been affected by COVID pandemic and lockdown, which one can understand. And then at the end of this round, just let me about new approach is obviously what you probably heard about is long-acting antiretroviral. The two main one are NNRTI-based rilpivirine and integrase inhibitor-based cabotegravir. But the potential advantage of long-acting is less frequent dosing, avoid pill, tablet fatigue, less adverse events, less drug-drug interaction, protection of privacy, avoid HIV stigma. The question is still, we still need evidence really whether this approach going to make an impact on adherence. There is some challenges of those long-acting, the injection volume, the need for oral lead-in, the missed dose, what happens if someone missed their only monthly or every 2-month dose, impact on possibly drug resistance if they miss the only one dose during the month, management of drug-drug interaction may be an issue, irreversible adverse event, or dosing for children is not yet defined, or pregnant women. So this is a table with all the long-acting under development. I just mentioned the rilpivirine and the cabotegravir, which are advanced phase 3 phase. And I can only share one, which is the New England Journal paper by Sue Swindell, looking at cabotegravir and rilpivirine for maintenance of HIV suppression. So those are patients who are supposed to be virologically suppressed at baseline, and then they randomize them to get either the standard of care, oral, PI or integrase or NNRTI-based parts, versus long-acting with rilpi or cabotegravir. So they've been able to show that monthly injection of long-acting cabotegravir and the rilpivirine versus was non-inferior to the standard of care. So this supporting the possibility of simplification of treatment with those long-acting. Again, as I say, the issue is whether patient going to accept injection instead of oral tablet. And there have been some issue in some of the study of reaction at the site of injection, like pain or swelling, but not at the point that they need to interrupt treatment, but they were just uncomfortable. So there is also the issue about acceptance. But again, as you just show from this data from the New England, those are patients who are fully suppressed, though. This approach will be really useful mostly on people who need them, those people struggling with non-adherence. So we still need to show study which randomized patients who are non-adherent at baseline. So those studies are just ongoing. So I cannot tell whether really this approach of long-acting gonna really make a difference in patients struggling. But in patients who are stable, who are virologically suppressed, it's non-inferior to standard of care. So the future of those long-acting in terms of improvement will be to try to have a microneedle patch, which may be less painful, less swelling reaction at the site of injection, or new implant technology, or combination technology like a ring or gastric reservoir, which is going to help also approach that, going to help to reduce the volume. So as I say, there is also some logistical challenge in clinic for those long-acting, capacity of staffing support, monthly drug product storage, cold chain storage, capacity of staffing to support monthly retention. But in overall, this is an approach that is attractive, but we still need more data and a more follow-up before we embrace it widely. So, my overall conclusion is also there been a progress toward achieving 90-90-90 target. We are making there. The COVID seems to have disrupted mostly treatment initiation, but in overall, people being virologically suppressed. Despite the 90-90-90, the new approach of improving treatment adherence will look at long-acting injectable or oral or other mode of delivery to make them acceptable and to prove through new study that they help those people who really need them. So I'm going to stop here and happy to take any question, any comment, and I thank you for inviting me again to Sao Paulo, at least virtually. Thank you.